Hello everyone, welcome to ESMO 2024. I'm here with Dr. Martin Reck. He's the well-known, recognized leader in publications in lung cancer. He presented today very interesting data about ctDNA in patients treated with neoadjuvant chemoimmunotherapy. Thank you, Dr. Reck, for having the time to be with us.
Yes, my pleasure.
Now we have several trials having a benefit in EFS at least, of giving chemo plus IO for patients in neoadjuvant. Do you think this is the standard now for all the patients with stage 2 and 3 disease?
Well, actually, we have different treatment opportunities. We have the neoadjuvant therapy, we have the adjuvant therapy. We can combine this as perioperative treatment. Currently, we do not really know what is the best treatment for individual patients. We have seen this year data for an adjuvant treatment with durvalumab showing no difference to the control arm. So we do have the feeling that neoadjuvant chemoimmunotherapy might be very important for patients in stage 2 and 3 resectable non-small cell lung cancer. I think in stage 2 we still have to look on the individual patient, and we have to talk to the surgeon. This is always a multidisciplinary decision.
Exactly. With the updated data that was presented at the World Lung just 2 weeks ago by Haymark, how do you make with this new data about the EGN trials, and how do you think it pans out with the other combinations of IO chemo?
Well, I think for all the trials we have a very consistent signal that with the neoadjuvant chemoimmunotherapy you can improve the PCR rate and you can prolong the event-free survival. We have the first signals also on overall survival for EGN. The problem is that we still have a high rate of censored events. And I would say in general, this is a comparable effect that we do see across all these trials with neoadjuvant or perioperative treatment.
Yeah, we can say that we can cure 15 to 20% more patients just by giving the IO combination up front. Can you just summarize the data that you published today about the ctDNA, the analysis of the ctDNA during EGN? I think it was very interesting data. I just don't know how we're going to put this, and we're going to talk about this in context with the practical issues. Can you just summarize quickly?
Yes, pleasure. So I think what we wanted to know is, do we have a factor for selecting patients who have a high risk for relapse? And could we have a factor for select those patients with a high chance of early PCR? So these have been the two questions. And what we did, we generated individualized tumor panels of the patients. We did this by sequencing the diagnostic biopsies, and we presented data on 283 patients. This was the biomarker evaluable population. And we looked on the ctDNA clearance during neoadjuvant therapy. We looked also on the post-surgical ctDNA positivity and the impact on disease-free survival. And what we did see, I think, in principle, we had 3 important outcomes. So number 1, in patients who were ctDNA positive at the beginning of treatment, all patients who had a PCR after neoadjuvant chemoimmunotherapy and surgery had a complete DNA clearance.
Yeah.
On the other hand, patients who didn't achieve a ctDNA clearance were also quite unlikely to achieve a PCR after surgery. And there was a difference in the treatment effect. So among those patients with the ctDNA clearance, patients in the durvalumab arm had a higher chance to get a PCR compared to the placebo arm. And this also was seen for other efficacy parameters like event-free survival and overall survival.
Yeah, that was very interesting. In practical manners now, do you think we are close to, when we see a patient, now we order a PET scan, MRI for patient with stage 3, an NGS, because we need to select the unmutated patients. Do you think we're going to have to order a WES, with a whole exome sequencing to find out the ctDNA?
I think currently we are not there. So this approach was a very ambitious approach. The individual tumor panel, which was generated, this is not feasible in daily practice. And but this is the first step, and we should follow up. We have now a trial, the Bridge trial, where we are advancing this technique, and hopefully in some years we will have a panel available which is number one achievable and number two feasible, and hopefully we can use this panel to identify those patients who have a high risk of relapse after surgery, because this is the critical question. How do we manage the PCR negative patients? How do we manage the patient without ctDNA clearance during neoadjuvant treatment? There we need new strategies.
And do you think eventually we can select patients that do not need adjuvant treatment? Let's say the patient that has negative ctDNA from the beginning. We didn't see that data, but do you think we eventually going to select those patients not to receive systemic therapy?
So I can tell you, we looked on the ctDNA positivity before beginning, and actually these were very, very few patients. So these were less than 10% of the patients that we investigated. But I think this early snapshot of early ctDNA clearance might help to identify those patients with a long tumor control. Interestingly, when we look on event-free survival, we could identify more patients by the ctDNA clearance who had an event-free survival benefit compared to the PCR. So this is a very valuable instrument. Whether or not these patients should receive adjuvant immunotherapy, I think we need some more follow-up, because this is currently still a limited follow-up period that we do have on all the trial populations. But hopefully this might help us to stratify our patients in terms of adjuvant therapy.
A couple of tricky questions. I know we don't have answers for this, but let's say a patient that started chemoimmunotherapy neoadjuvantly, and after 4 cycles is still positive with ctDNA. Do you think the future trials are going to re-randomize these patients to more chemotherapy, to increase the immunotherapy? Where do you think we're going to go with those patients? Or are you still going to operate those patients to not miss the chance of curing those patients?
Well, actually, if this patient is resectable, he should move to surgery. The question is how to proceed then. And there is a new generation of trial ongoing on those patients who are PCR negative, looking for novel treatment opportunities. Currently, we are expanding our, I would say, systemic treatment opportunities, options. Actually, I also think that we have to revisit radiotherapy as a very effective management opportunity for this group of patients. But this is a new generation of trials which exactly is addressing this group of patients.
Last question. When you're going to follow up those patients, if we decide in the future to follow up with ctDNA, because we can see that we can find patients ahead of their radiological progressions, do you think this is going to be helpful, or is this going to just create more anxiety to patients, because once they become positive, they're going to get scared and anxious about their radiation? I don't know what's the lead time bias that you found on the trial, or how long it takes for the patients to progress radiologically.
So we have some data from the ADAURA trial where we have done this, and we have seen that, let's say, the metabolic progression is 2 to 3 months earlier before the radiological progression. Whether this is also true for patients after perioperative chemoimmunotherapy, we need to determine. I think hopefully this might help us to identify the early relapse, but we are not there. I think we need to investigate this in the context of a controlled clinical trial, and definitely we need more data. But hopefully this might be an additional instrument that we might use for our patients. Whether not this ctDNA change will trigger any therapeutic intervention also needs to be determined. I think we are quite early there, but I'm quite happy that we have this additional marker.
Exactly. I think this is a great field of investigation. It's the beginning of a great possible test that we're gonna have in the future. And this is a great presentation that you gave us today. Thank you again, Dr. Reck, for being here with us and for all the work you've done with the patients for lung cancer.
Thank you.